Okay. So relapse on corticosteroid withdrawal may be because azathioprine has not taken effect, or we have not given adequate azathioprine dose. Maintenance dose is that lowest effective corticosteroid dose before relapse is your maintenance dose. Now, assessment of management of the relapsing patient with myasthenia. So, if a patient comes to you with a relapse after you have you're reducing the dose of steroids, on what should we assess? One is determine whether the patient's deterioration is a myasthenic relapse or a side effect of the treatment of another condition. Is the deterioration due to intercurrent infection? When they talk about or another condition, it means intercurrent infection, the most common cause of relapse after drug reduction. As the patient received medication that causes myasthenic weakness, also need to be assessed. Because of infection, if the patient is on antibiotics, or for some cardiac illness they started beta blockers, need to assess. Is the deterioration a consequence of changes in treatment, particularly steroid withdrawal? Did we reduce the dose too fast? Should be our thought. So one, rule out to see if it's a myasthenic crisis, see if it's an effect of another treatment or our treatment. Third, look for another condition like an infection. If the cause for myasthenia deterioration can be found, manage the cause. So first rule, always manage the cause as to why it's happening. So patient with myasthenia deterioration should return to the steroid increase protocol. And the max dose here will be 100 or 100 milligram or 1.5 mg per kg. For generalized and for ocular, it will be 50 mg or 0.75 milligram per kg. Or the same steroid escalation protocol. One, find the cause, treat the cause. Second, start steroids and reach a maximum. And if the patient is on 15 to 20 mg alternate days if the patient was not receiving azathioprine, then start azathioprine. If the relapse may have if the patient was on steroid withdrawal on azathioprine, then increase the steroid protocol. Also, the relapse may have been due to short duration of azathioprine for maximum efficacy. Okay, to clarify, so one, treat the cause, start steroids. Third thing, if the patient before relapse was on more than 15 to 20 mg per on alternate days and azathioprine was not started, in that case, start azathioprine. And the other condition is patient was on azathioprine and you were reducing the dose. You felt the patient was on remission. Before relapse, the patient was on reducing dose and the patient goes into relapse. What do you do? That means azathioprine has not taken effect or the dose is too less. But we have to, since the patient is in relapse, we'll have to continue steroid escalation protocol and go back to till maximum or a patient symptom control is achieved. So inpatient management for myasthenic crisis, patient should be managed in hospital for significant bulbar symptoms, low vital capacity, respiratory symptoms, or progressive deterioration. Assessment by speech and language therapist to advise on swallowing is mandatory. What all should we do when the patient is in the hospital? So regular assessment of vital capacity is mandatory. So speech, language, vital capacity should be handled. In case of severe bulbar respiratory symptoms, 1 to 2 gram per kg dose of IVIG. If there is risk factors for IVIG, try plasma exchange. Prednisolone, start by standard protocol for generalized myasthenia gravis. These three can be tried basically: IVIG, plasma, prednisolone in an inpatient setup. So for ICU management, there are two groups of patients: for ventilated patients and for non-ventilated patients. For ventilated patients, start prednisolone at 100 milligram on alternate days and start IVIG immediately. Avoid inappropriate use of intravenous magnesium. Consider avoiding pyridostigmine, neostigmine, as there may be increased secretions. So it can cause a tube block. So that's why avoid giving pyridostigmine, neostigmine. So IV magnesium in case of preeclampsia should be avoided, or management of asthma, things like that, to avoid IV magnesium. For non-ventilated patients, Start prednisolone following the standard protocol for generalized myasthenia gravis. Start IVIG immediately because transient weakness can be there because of the steroid. Initiation of corticosteroids can transiently cause worsening of myasthenia gravis. Simultaneous initiation of anyway steroids will take 2 to 3 weeks to act, and meanwhile we can give Plex and IVIG for symptom control. Now coming to the guidelines, those were the British guidelines. Now according to the international consensus, it's pretty much the same, but stressing on certain points. Pyridostigmine should be the part of initial treatment. Dose should be adjusted based on symptoms. The ability to discontinue pyridostigmine is an indicator that the patient has met goals. And this is a guide for tapering therapy. Corticosteroids or immunosuppressive therapy should be used in all patients with myasthenia gravis who have not met goals. So alone with pyridostigmine, we can achieve goals. When do we initiate? A non-steroidal immunosuppressive agent should be used alone when corticosteroids are contraindicated or used. A non-steroidal immunosuppressant agent should be used initially in conjunction with corticosteroids when the risk of side effects are more, or the comorbidities, like in case of diabetes, ischemic heart disease, like I mentioned. So a non-steroidal immunosuppressant, we know when it should be initiated, when the response is not adequate, when there are side effects, or when the patient is not tolerating the corticosteroids. So what are the agents that can be used? Azathioprine, cyclosporin, MMF, methotrexate, and tacrolimus, according to the 2016 guidelines. So these factors, even though the studies, they have mentioned in a note that the studies, it's mostly these immunosuppressive agent, the studies that they have done are very small. They have taken into consideration, the studies include hardly only 150 patients of myasthenia gravis, the maximum. The biggest systematic review included 160 patients of myasthenia gravis. So what they are saying, most of these guidelines that we are seeing are expert consensus in that group of doctors that were assigned. So the following factors should be considered in selecting among these agents. There is widespread variation in practice with respect to choice of immunosuppressant. Expert consensus and some RCT evidence support use azathioprine. That's why we are initiating azathioprine. And based on not only this condition, based on other conditions they've seen that azathioprine has a maximal effect. That's why we're using here. Evidence from RCTs support the use of cyclosporin, but potential serious ADRs and drug interaction limits its use. So after azathioprine, cyclosporin will be the second line of the treatment. Although available RCT evidence does not support the use of MMF tacrolimus because there are not many studies. In myasthenia gravis, both are widely used and one or both are recommended in several national myasthenia gravis national guidelines. So they are also saying that refractory MG, myasthenia gravis, use chronic IVG, Plex, cyclophosphamide, rituximab. In 2016, they had not come into a consensus that rituximab needs to be used or not. There were many studies going on, but according to 2020, we'll be talking about that. Immunosuppressive agent dosage and duration of treatment. Once patient achieves treatment goals, remission, or that is, goals are minimal manifestation status with ADR, CTCAE1. Those are our treatment goals. Corticosteroid dose should be gradually tapered. In many patients, continuing a load of corticosteroids long-term can help to maintain the treatment goal. So that is, our low dose was to maintain it around 7 to 8 milligram. For non-steroidal immunosuppressive agent, once treatment goals have been achieved and maintained for 6 months to 2 years. So you have to, for steroids, it was 3 months. 3 months patient needs to have treatment goals for us to start tapering. Here, patient on second immunosuppression, you need to wait for 6 months to 2 years. The immunosuppressant dose should be tapered slowly to the minimal effective amount. Dose adjustment should not be made more frequently, more than 3 to 6 months. Once in 3 to 6 months, you can adjust the dose. That's all. There is a risk of relapse, which may again necessitate upward adjustments. Sometimes you'll have to maintain immunosuppression for life. So, and on the use of immunosuppressant, as mentioned before, you need to monitor the adverse drug reactions. So our goal here is one, to achieve treatment goals. Second, to achieve minimal effective dosage with respect to corticosteroids or immunosuppressive agents. But we need to wait a considerable amount of time, at least 6 months, before you start thinking of tapering. And even if you're tapering, don't taper it too frequently, more than once in 3 to 6 months. And of course, we need to keep a watch out for adverse drug reactions. Now, what is the 2020 update of ocular myasthenia gravis? So, if the ptosis in ocular is not responding to acetylcholine agents, should be treated with immunosuppressive agent if symptoms are functionally limiting. That is, if the patient is complete ptosis, unable to function or work, then you need to initiate immunosuppressive agents. Corticosteroid should be the first immunosuppressive agent. Steroid sparing may be needed if corticosteroids are ineffective. Data from a single small RCT suggests low dose corticosteroids may be effective for ocular myasthenia gravis and may avoid side effects associated with high dose steroids. Acetylcholine receptor antibody positive patients with ocular myasthenia gravis who do not respond to your pyridostigmine and either prefer not to take immunosuppressive agents may be offered thymectomy. So in this, if start with pyridostigmine, if the pyridostigmine does not have effect and if the patient has limiting issues, then start immunosuppressant. If you're starting immunosuppression, corticosteroids followed by an additional immunosuppression only if the patient is not tolerating corticosteroids. And in antibody positive patients, and if the patient is not responding to pyridostigmine, not willing for steroids, offer thymectomy. What is the 2020 update on rituximab? Rituximab should be considered as an early therapeutic agent only in masked antibody positive myasthenia gravis. There is one trial called BeatMG trial which tells that rituximab is not effective in ACHR receptor antibody pus. But there are a lot of issues with that trial itself. One being that the patient had all of them had very mild disease. And they didn't see a significant difference between rituximab and placebo. That's because most of the patients that were recruited in that study were of mild disease. But they've taken that into consideration and found out that ACHR antibody can be used, but only if other immunosuppressive agents have failed. But in masked antibody positive, they say try it as an early therapeutic option or a first line of management. Methotrexate, very limited evidence, but expert consensus says you can use it as a steroid sparing agent. Eculizumab, it has been approved by the FDA, and by the way, rituximab is not approved by the FDA. Eculizumab, though 2017, after 60 years, is the first drug to be approved by the FDA for myasthenia gravis management. So it is used in refractory ACHR antibody positive generalized, not for MuSK. As I told you, this affects the complement system. It avoids formation. It goes and binds to the C5 and prevents its degradation to C5A and C5B. C5B then progresses and combines with C6, C7, and forms the membrane attack complex. So it very strongly binds to C5, prevents its cleavage. The role of eculizumab is likely to evolve over time until further data becomes available to allow comparisons of cost and efficacy. Though this has been FDA approved, there are actually the study was also quite small, which was studied for eculizumab, and the cost, the pros over cons need to be thought about before treating the patient. That's why they've mentioned severe refractory. It's been approved for severe refractory cases of ACHR antibody. So the only issue with eculizumab is meningococcal meningitis. So vaccinate the patient for Neisseria meningitis, and you have to use all serotypes. You have to use ACWY serogroup and ACWY conjugate and serogroup B vaccine. Both needs to be given, and it needs to be given 2 weeks before initiation of eculizumab. And if you do at all give the vaccination and you start the treatment within 2 weeks of initiation of eculizumab, then you have to give antibiotic prophylaxis. So, and actually, because we'll be talking about it later, but the effect of eculizumab is seen within 1 week. So they are doing further studies to evaluate its efficacy in crisis as well.
Now you tell us how many more slides are there.
I think I'm almost done, sir.
I don't think so. You're at 55 and you said you have 90 slides.
But sir, there's hardly anything.
We will have to shut down OPD. So we can't do that.
Shall I continue tomorrow?
Why can't you keep it short?
So these are guidelines for how to keep it short.
Everything can be shortened.
And I mentioned only not even reading the slides. I'm mentioning 2 to 3 words about each slide because it's
Which is more than what is there in the slide. Okay, so we will continue with this, sir, because we're only halfway through the slide deck.
there is novel treatment.
We have to continue more. There are some things which are not clear. If somebody has only ocular symptom, ocular myasthenia, but has high antibody titers, how do you treat that?
For antibody titer positive AChR receptor antibody positive, we can in less than 40 years we can offer thymectomy, but nothing has been given with respect to titers of antibodies and the treatment protocol. This is purely a clinical management, is what they said. If
somebody has ocular and we have recent generation, high antibody titers, only doses, clinically no other muscle weakness, but electrophysiologically there is generalized myasthenia. You treat that as ocular or generalized?
If the patient might have symptoms like fatigue, so they're saying
no
fatigue.
Other than where is it given?
Not given.
You told me that.
You have to wait until
No, I've read all reference. There's no reference.
There is a situation like this which we have seen quite a few times. Patient comes with only ptosis or diplopia, but there is no clinical evidence of fatigue or weakness in the limb muscles or burglar muscles or facial muscles. But electrophysiology shows decremental response in the limb muscles. You treat that as ocular myasthenia or you treat it as generalized myasthenia? Check. I mean, your
Yes, sir.
And what the age cutoff for thymectomy?
40 is what they've given.
40.
Every 40, 45 is what they.
Some books still mention 60.
This is 2020, but till 2020 is 40.
Check that also. And that applies only if the thymus is normal. If there is thymic enlargement, thymoma, age is not affected.
So they're saying in patient with AChR antibody positive patients, that might not be a recognizable enlargement. It might be on a pathological basis that there might be hyperplasia of the germinal centers in the thymus. So we can still offer, if there is no visible thymoma on a CT or a hyperplasia on CT, we can still offer them if AChR antibody positive status in patient positive.
that is young patient. In any patient.
No, otherwise also you need not see a recognizable mass.
Non-thymoma.
Correct. We need not see a mass or
age.
Non-thymoma,
then you offer only younger age.
So the issues are in 75% with thymic abnormalities in AChR antibody positive patients. 65% are hyperplasia, which is seen visible only at a pathological level. Like on histopathological level, you elicit or see hyperplasia. On 10%, it is thymomas and visible.
So how do you know that? If somebody has a thymic enlargement, is say 55 or 60 years old, what will you do?
So there is statement that we can offer radiotherapy or we can offer, sir, and other palliative managements of thymus gland tumors have been there that I saw. Even in elderly patients with significant morbidities, if you are unable to perform surgery, the surgery benefit of surgery might not be significant because they might have what happens is these antibodies, there is antibodies present in the secondary organs, not only in the thymus. After certain exposure to certain duration, these antibodies go and settle in other periphery glands which we cannot resect. So the efficacy of thymectomy in patients after 40 years of age, that is why it's not efficacious. I remember reading it.
But if there's a thymoma, then
what if there's a thymoma?
Then we can remove it, but they can't expect improvement. That
Yeah, there is a 30% cure rate
in elderly patients.
in elderly patients.
That I'm not sure. So because of the peripheral deposition of the antibody,
No, if there is a thymic enlargement of the scan.
resect.
How do you, how do you know it's thymoma or just thymic hyperplasia?
Irrespective, we have to resect, sir. They're not saying this.
No, you are saying if it's hyperplasia, then there is no need to operate.
No, sir. What I'm saying is you might not see it, but you still have to go ahead with the thymic resection. What we should not focus only on thymoma and resecting. We have to still offer thymectomy.
Only about thymic resection.
We have to offer. We have to offer if the antibody is positive. That's all. Like if there is an age criteria, but that is only because the improvement in symptoms might not be present. There might be deposition. But if ACH or antibody positive status, you can go ahead with thymic resection is what I'm telling.
I think how do you know it's just hyperplasia?
You don't have to know is what I'm saying. In CT, if it's visible, it's
That's the
thymic.
point. If there is thymic enlargement, you resect regardless of age.
Yes.
That's the thing.
So it is like if we say, sir, we keep our improvement and then we see or we know directly.
That's all. Correct, sir. And but they might not see improvement after a certain age because there are peripheral deposition of the antibodies. The issue is not only with the thymus.
You have to take it out. Even if the person is beyond 50 or 60,
Yes, sir.
if it is enlarged, you have to take it out.
Here there is a study where they have said that even in cases in old and morbid patients where you can't offer surgery, you can offer palliation, palliative chemotherapy radiotherapy.
So it's very clear that thymic enlargement removed,
Removed.
irrespective of age.
So age criteria doesn't apply.
Okay, and if thymic enlargement is not there, still removed in
Removed.
young patients.
In antibody positive patients.
Yes. But the age criteria was 60 according to me, you're saying 45. So till 60 you could offer for all myasthenia patients thymus removal, irrespective of whether it is visible or not.
Do you offer it in musk positive patients?
No.
Musket is not. Yeah.
Hmm.
Musket is not proven to be effective. ठीक है चलो बिल्कुल ये नाले क्यों नहीं It's 9:30.